This conference.
Guess we're recording.
We are.
Les, do you have anything tonight you want to bring up?
No, sir.
Okay, how about Larry? Larry Fish, do you have anything tonight?
No, thanks, Peter.
Okay. Okay, my name is Peter Kafka. I'm moderating the meeting from Maui, Hawaii. And a word, a shout out to our sponsors, which we don't do every week, every meeting. We're thankful for them for their financial support and recognition of the value of peer support. And those include Bayer, Pfizer, Johnson & Johnson, all pharmaceutical companies, Blue Earth, Telix, Sumitovant, Myriad Genetics, and Foundation Medicine Genetics. So we're grateful for them. We're not endorsing their products. However, many of us have used them successfully and otherwise, and they play a big role in our adventures moving forward step by step, sometimes in leaps and bounds. So we're thankful for them, and I trust they are thankful for us. Julian, you got in under the wire here. Do you have anything updates tonight or anything you want to bring up? Well, Julian, if you hear us, just give me a thumbs up if you have something, or shake your head
No,
if not.
no, nothing for me. Thank you.
Okay. Okay, well, let's get going here. So I promised, or we promised, Jimmy Greenfield. He got kind of got the short straw last week and timed out and missed his update. So he's up first because there's nobody new on that I know of or I can see. So Jimmy, take it away and let's hear what you have to say.
Thanks, Peter. Hello, everyone. So what I love about this group, one of the things I love about the group is that whenever I'm going through something that's particularly troubling to me, the difference between thinking that I'm alone in that and I'm the only one who's going through it, and thinking this is something that many people have, is the difference between me feeling sorry for myself or not, basically. I don't go that far, but I say that it helps. The empathy is very helpful. And sometimes, I just got a weirdo problem and I got to deal with it. And that's what I actually do instead of feeling sorry for myself usually. So about 10 years ago or so, I started getting urinary frequency at night. And I probably got up a time, in the night. Back then, when I was just a young man with a dream, 57, I probably thought, well, this is weird. I should do something about it. So instead of getting a PSA test or going to a urologist and a doctor and trying to see why I was getting up at night to pee, I just decided that I would get some saw palmetto and that I had BPH, and I would just, self-diagnose and just roll on. So I did that for 6 years, and probably my cancer was growing the whole time. About 2019 or so, or early 2019, my wife, who, like a lot of us, without her, I would probably be shaking a cup or under a bridge, or I don't know how bad it would be, but it would be bad. Or at least it wouldn't be as good. She said, why don't you go to the doctor? You're getting up 2 or 3 times a night. I said, okay, I'll go to the doctor. Went to a urologist. I blew a 16.4 or whatever it was. And that started my prostate cancer treatment path. So after the surgery and the radiation and the abiraterone and the chemo and the kitchen sink, the net effect, artificial urinary sphincter also for incontinence. The net effect is that I just couldn't hold my urine very much, and the frequency at night was worse than ever. But it still was only maybe every 2.5 hours I was getting up, and I really just didn't mind. I could go back to sleep pretty easily. But over the last 6 months or to a year, it started to get more frequent. I get up. My intervals of sleep shortened from 2.5 hours, 2 hours to an hour and a half, and then shorter. And now, in the last 6 months or so, it's been more like 45 minutes to an hour a lot of the time. And what I find is, since I've investigated this a little bit, and I learned that sleep cycles are 90 minutes to an hour and 10 on average, and that average person sleeps through the night. They think they do, but they wake up, after a sleep cycle all night long. They just don't realize it. They wake up so briefly and so gracefully, so to speak. They just go right back to sleep. That's the normal human condition, at least when you're younger, I guess. So anyway, at some point, a couple of years ago, I started to take some bladder relaxant drugs, and we've had some conversations on here about it. I tried I tried oxybutynin and trospium and a couple of others, and I decided they didn't work because they didn't work perfectly. And that's kind of like the dark humor I find about this. If back in 2013, when I was having all that frequency of getting up one time a night that I thought was so onerous, that would be a dream if I had that today. And in the same way, when I re-challenged with these drugs, I had some lying around the house. And maybe I'll try this trospium again about 6 months ago. Works very well if you take it for a little while. You just start to get in the hang of it. So basically, I'm not getting up. I'm not being woke up by my bladder, but I'm habituated to wake up. And this has been going on for a very long time. So I'm trying a lot of different things. I did a take-home sleep study to try to rule out apnea or restless leg syndrome, other things that they measure with a sleep study. Of course, they give you the take-home study. I don't like to be cynical, but they give you the take-home study because insurance doesn't want to pay for the full study, which is very expensive. But then if you're not satisfied, you can go back and you can ask for the full study. And I've asked for that, and I'm going to get that. But first, I have to, of course, meet with the neurologist again, and that's a wait until July. So in other words, they got me right in. They got me in July. That was like a couple months ago. But that's what it's about now sometimes, as you know. Sometimes I tell you with a straight face, yes, Mr. Kafka, we can get you in. We get you in right away. April of 2028. Can we put you down for that? They'll say it with a straight face. But I didn't complain. I took that. I got a couple of other appointments. I'm going to seek that out. But in the meantime, my sleep is so poor that it's really starting to, it's disturbing. It's distressing. It's affecting my mood. It's affecting what's left of my mind. It's, I don't want to be too dire about it, but it's been tough. And so my simple question is, while I kind of get this sorted and while I continue to do all the sleep hygiene things and go to bed earlier and get up earlier and, et cetera, et cetera. My simple question to you guys, is there anybody on this call, just today, for instance, that does not sleep in intervals longer than an hour at a time through the night on the regular? I see Jack.
Well, I'm on a 2-hour cycle, Jimmy. I've been on a 2-hour cycle for years. I attribute it to a stiff bladder or something. I don't know, but I'm up to pee every 2 hours. And if I'm not feeling well or if something's a little bit off, it's every hour that I'm up. I've noticed that. And so that'll happen every 2 or 3 months, and I'm up every hour. And I know that because my clock glows. I watch. I know exactly when I'm up. Fortunately, I fall right back to sleep, but I'm very similar to you. I agree with you. If it wasn't for my girlfriend pushing me to see a doctor, I would have said, "Oh, no, it's just enlarged prostate." But it's been that way for years for me, and I know it disrupts my sleep cycle, but I've just kind of decided to just go with it. I don't know what else to do. So I'm in your court, but I feel for you. If it's every hour, that's got to be pretty unnerving because I know what
Well,
that's
as I
like.
said, when I found
Feeling.
out that sleep cycles are 90 minutes long, it makes sense that 2 hours at a time, I feel very differently. I can sleep 2 hours at a time. If I put enough of them together, I'm fine. If I sleep 45 minutes to an hour at a time, it doesn't matter how many of them I put together. I'm terribly sleep deprived. So,
And even with the exercise you do vigorous
I'm a-
exercise in the afternoon or
I'm
early
ex-
evening?
Yeah, I'm extremely fit and extremely sleep deprived.
Gosh, I don't know what to say. Anybody else have any thoughts or comments here?
Jack says something. Jack.
Yeah, well, I'm certainly sleep deprived. I've had a sleep disorder for so many years now, and now that I'm taking this medication, I find it's really, the night, the hot flashes, the night sweats, throwing off the covers, it just comes, so frequently during the night, and also, some skip beats and all kinds of other problems I've had with my heart. So I've had a lot of difficulty sleeping for a long time, and then I monitor it with my iPhone, and I can see actually how much deep sleep I get. Very little deep sleep, very little REM sleep, and a lot of interruptions. So I take Ativan, lorazepam, take 1.5 before I go to sleep, and then sometimes in the middle of the night I get so disgusted. It's only 1 o'clock in the morning. I jump out and I take another half a pill, and that's not good. And I've been told by sleep specialists and other physicians, don't do that. It's too much. You're going to get habituated, hooked, and it's not good for your respiration. But I don't know what else to do. I tried hot baths. I tried counting and every day, all kinds of. Stay away from watching television at night, which is hard. Reading books. Tried all the sleep hygiene. My mother had a sleep problem too. She slept her whole life. She couldn't sleep, and I don't know if it's a genetic thing. My father slept. It's tough.
Yeah, the other thing is that, I sleep usually for, an hour and I get up, and then if I'm real lucky, I'll get 90 minutes in. If I get 90 minutes in, I feel like I've slept for 14 hours.
Oh,
It's the
90
difference.
minutes is great.
But then I can't go back to sleep for a little while. And then I have to, decide if I want to take a pill. I got a couple of different things that I don't like taking, but if I have to, I take them. But yeah, I hear you, Jack. I'm sorry for this.
Have you
Fortunately, you're
tried,
tough as nails.
did you try that pill that was suggested by one of our members called Gemtesa?
I tried to get Gemtesa, but it's fabulously expensive. I did get Mybetriq, which is also very expensive, but I didn't find it performed any better than the Trospium, which is dirt cheap. So I think I'm going to go back to Trospium. Of course, I'm going to use the rest of my 30-day supply of the Mybetriq because it's every time I look at it, I think about how much I paid for it. So I want to take it all, so I don't have to think about it anymore.
Jimmy, I mean, you said to me that you don't think that it's the frequency and the bladder that's waking you up at this point in time, that you're doing much better with the Mobegran.
Well, not better with the Mybetriq. The Trospium, once it kicked on, was good. Been monitoring the Mybetriq to see if it's better than Trospium, but to be honest, I don't see any difference. The Trospium was really working pretty well. Like I say, when I first took the Trospium a couple of years ago, I didn't like it because my expectations were very high. This time I was more desperate, so that when it worked only somewhat well, I was pleased. I don't think it's any different.
The question is the incontinence still waking you up? Is the bladder urgency still waking you up, or is it something else?
No. I think it's just being habituated from waking up so much, and I'm in a pattern of waking. At the first couple of times I get up, I have some urgency, and I can't hold very much. But then, after about 3 in the morning, there's no. I'm waking up anyway with no urgency at all. So I'm still waking up.
So Dr. John, do you have any suggestions as how you can get rid of this habituation when you've just become so used to it for so many years?
Well, I think you pointed out an important thing, Rick, which is that it's probably not bladder spasms that are waking Jimmy up. You'd think that something like oxybutynin or Gemtesa would relax bladder spasms, let the bladder fill up. In 45 minutes, I mean, even if you're drinking heavily in a bar, you can't really fill up a 500 cc bladder to the point where you're having bladder spasms. So something else is going on. I agree with Rick about that. Jimmy and I once talked about this thing called psychophysiologic insomnia, where you get you get conditioned after a period of time. It might start with an organic bladder illness or something like that, but you get conditioned to have anxiety around bedtime, and you particularly get conditioned to have anxiety when waking up in the night, because once you start thinking, I'm not going to fall asleep, you're guaranteed not to fall asleep. Jimmy has tried a number of the sleep hygiene methods and behavioral treatments for psychophysiologic insomnia, and he might have to get more drastic about that, instead of just having a regular wake up time every day and not taking naps. And he might have to go to the step of doing things like never doing anything in bed but sleep, getting up and sitting someplace else when he wakes up at night, and only going to bed when he's ready to fall asleep. These kind of behavioral things they drive you crazy at first, but they can be effective over time. What's different about Jimmy, and it's really frustrating, is that hopefully he's got an overnight polysomnographic sleep study coming up, which is going to answer all these questions for us. It can, but it's months and months away, and he'll be like 100 years old from insomnia by the time July gets here, and they'll be just scheduling his sleep study by that time. So whether to go ahead and do the whole full behavioral treatment for psychophysiologic insomnia without a definite diagnosis, I don't know. I like to wait for the sleep study, because then you have so much diagnostic confidence. And then I had a comment also for Jack. Didn't one of us run across a study last year about lorazepam and cancer recurrence? Anybody remember that?
Yeah. I think Rick brought it up and we talked about it. And the probability of lorazepam, Ativan, contributing to prostate cancer or any kind of cancer seems so low because the cohort study was so small.
Oh, okay.
It's never been published except for this one study. And if that was really a documented, realistic assessment, somehow or other we would have heard about it by now, because so many people use lorazepam, or Ativan, and to not hear about it in the literature just seems very strange.
Okay, so we decided it wasn't necessary to switch benzos or anything like that. Okay.
Yeah.
Jimmy, what's your energy like? Your energy cycle during the day? Are you pretty even and consistent, or I know in my situation, I reach a point around 7 o'clock at night where I get pretty darn wasted and kind of can't wait until 11 o'clock when I can crash, if I can make it that long. What are you like? Do you keep chucking along all day long, and do you drink coffee in the afternoons at all?
No, what it is with me is that I crafted my life around not going to bed early. I was a very nocturnal, like cliche, but rock and roll guitar player, nightlife kind of guy, forever. Stay up late, get up late. Don't have any kind of job or career that requires getting up early. That was what I aimed for, and I made it. I worked in the restaurant business for 30 years, where I could subsidize being a musician, never had to get up early in the morning. I was one of those guys that thought that, life wouldn't be worth living if you had to get up early. Now, like a lot of us, things have changed, and now the earlier I go to bed, the earlier I get up, I have better days. I get tired for sure, real tired at different points, but I find that the earlier I get up, if I get up at the same time every day, and I'm getting up at ungodly times like 6:30 now, that I never would have done before. And I have better days doing that than I do laying in bed and struggling trying to get extra sleep. So I think that's good. And the other thing is, I want to say that I have a April 15th appointment with a different neurologist and a sleep get a referral for a sleep study, because as AnCan said, if you're not your own best advocate, what are you doing? Because I even told my PCP that I had to wait until July to get this neurologist appointment when I saw him yesterday. And he didn't say anything. He's just like, oh, well, that's too bad. He didn't say that even. He just like didn't say a thing, because that's how it is now. But I set up an appointment with somebody else for April 15th. And I'm going to continue to do the things that seem like they're working. And it's basically, again, I try to find the bright side. The rule of thumb for me is if I do all the stuff I really don't want to do, then it gets better.
What about caffeine? Do you use caffeine at all?
I have a cup of coffee in the morning. And I'm
Just
about
the
ready
morning.
to get rid of that too.
Good.
That's the last thing I'm holding on to. That's like gonna the old pry the coffee cup out of my dead cold hand or something like that. I still want my morning coffee, but I don't know if I'm ready to give that up. But I'm ready to, I don't use the bed for anything but sleeping now. If I'm having trouble sleeping, I get up and I go sit in a chair and read. I don't watch TV. I'm just doing it. I think hoping these things will make a difference. But to be honest, I haven't been at them that long, so I can tell you if they work. You really have to stick with them for a while. If it took 10 years to get here, I'm not going to get out of it in a week. So I'm not really talking about that. I'm just, I see it as I pull all of you that Jack is the only one. Well, Peter, you have, 2 hours, but 2 hours is very different than 45 minutes.
I agree.
And, Jack seems to be the only guy that's right there with me, and I feel bad for him. But nobody else has got it to that degree, I don't think.
Alan, you've got something to say. You're muted. Alan, you're muted.
Jimmy, you triggered something with me. My neurologist wanted some MRIs done, and so I scheduled them. So he sent me a message, said, so what are they scheduled for? And I said, oh, the end of June. He got back, and he said, unacceptable, just totally unacceptable. He said, you get back. I want you to handle it first. Get back and tell them, and then you tell them to call me if they can't get them scheduled earlier. Damn if I didn't get them, call them back. And I said, well, Dr. Massey says it has to be earlier. Well, then I think we can get you in. I think it was April 11th as opposed to June 28th or something like that. It's like, what the hell? But so, just keep knocking on the door, I guess.
Well, I'm gonna close this down now because I want to hear from everybody else. But since I'm closing it down early, I want to give everybody just a little bit of an appropriate joke here that was told to me by my infectious disease doctor when he was trying to suss out these intermittent fevers I had. I haven't had a fever, by the way, for 6 months, so that's good. But I was talking to him, and I was talking about getting an appointment with somebody, and I said I had to wait so long, and he said, yes, it's the way it is now. And he's from the former Soviet Union, and he says, we have an old joke back in the Soviet Union and back in the Reagan years. I don't usually tell jokes to my patients, but I'm going to tell you. And I said, okay. And he said there was a guy who wanted to buy a car, and he went to buy the car, and the car dealer said, sir, there's a 10-year wait on that car. And he said, that's no problem, morning or afternoon. He says, it's 10 years from now. What difference could that make? And the guy says, I have a plumber coming in the morning. So that's enough for me. I'll leave it with that, and I'll keep working on it. Thank you all so much.
There's just one thing I want to add from Peter's comment, which is that if you're not having a lot of trouble keeping your eyes open during the day, if you're not falling asleep by accident when you
I
do
lay
something
down
boring,
for about 10 minutes if I have to, but I don't fall asleep in the middle of anything.
Then you really don't have to be too upset about your sleep being broken, because the purpose of sleep is to be alert and able to do things during the day. And if you can do that, then your sleep may very well be insufficient, but still you're fulfilling your basic need for sleep, and you don't have to worry that you're not getting enough. I know in your original overnight sleep study, you slept more than 7 hours that night, but that was many years ago. And it could be that your sleep has become so fragmented that it's driving you crazy, but you might actually be getting enough to fulfill the need for sleep if you're not sleepy in the daytime. Jack, on the other hand, I think is sleepy in the daytime, if I heard him right.
No.
No? Okay.
I wish I could. I could never nap. There's a genetic condition.
No, I don't want. I didn't mean that. I'm saying it's good to nap. I mean that if you're not having trouble keeping your eyes open during the day, then you actually are getting enough sleep during the night, even if it's fragmented.
Perhaps you're right.
Okay, one more comment. Jeff Wood, one more comment.
Jimmy, sorry for your that it's got to be frustrating. I just got an Apple Watch and it has a sleep, it monitors your sleep, and I was really surprised how often I do wake up. I wake up at least 8 times a night, not fully conscious obviously, but it's remarkable how much your body does come to attention in that sleep period.
Yeah, it's all about if you can just go right back to sleep. Yeah, everybody just wakes up and goes right back to sleep without even noticing it, and that's great. Well, I don't know what I'll do, but thanks everyone. That's enough for now, and I'll let you know if it gets better.
Okay, Jim Marshall, you're up next, but I want to ask Dr. Jeff if he's got anything tonight. Somehow I passed you. Do you have anything to bring up tonight, Jeff?
No, thank you.
Okay. Go ahead, Jim.
Okay, let's see, a little bit of the history. I was under treatment for 5 years, Lupron plus Zytiga. I have been on a 21-month treatment holiday. The PSA has risen to 273, and the PSA is now 0.03, so it has moved. Now, how quick it will move, I don't know, but that's my story, except for tomorrow, I get 2 stents tomorrow. So that ought to be interesting.
So 0.03.
Right, 0.03 hasn't been that for 6 years. So it is, yes, it still is
pretty darn low.
Starting to move. Now, how quick it will move, I don't know. I will just hang on and see.
Yeah, it's still pretty low. How often do you check it? Every 3 months or so?
Oh no, every month. I have every month for close to 6 3/4 years.
So 0.03, what was it last time? 0.01?
Less than 0.01.
The problem is it's not enough to say it's moving. Now, if next month it's 0.06, I can say. But I wouldn't conclude on the basis of 0.03 because it's too small. And we say this time and time. It doesn't matter how many times we tell you guys, don't conclude that your PSA is moving up or down when we're talking about what is it? 2 100? No, 2 1,000ths, I think this is. I don't know. Whatever. Don't conclude, I mean, people get so anxious. Observation. Now, what sort of stents are these? Because we have people with all kinds of stents, heart stents, kidney stents. What stents are they giving you?
These things are heart stents.
Heart stents.
Stents. Up through the arm, I'm told.
Okay.
It will be through the arm, not the leg.
Oh, okay. All right. Okay. Well, I don't know.
Outpatient, come home same day, they claim.
Well, I mean, I can only tell you that I thought I was doing good when I had a new hip put in same day in 5 hours until last night in Peter's group when one of the gents there said he had a hip put in 3 hours. I couldn't believe that one, Peter. What did he say? He got there at he got there at 10 o'clock, was it? And he was out by 1.
Yeah.
11 and 2. 11 o'clock and 2 o'clock. Oh my gosh.
Went through one of these drive-through hip replacement places.
That just kills me. That just kills me when I hear about stuff like, when Jack and I were in training, you'd go in the morning for a hip replacement. They'd put police tape across the operating room doors and you wouldn't even be out till late in the afternoon. Then you'd be in the hospital for 6 days or something. It just kills me when I hear stories like this.
Yeah.
It is. It's incredible. It's so I'm not surprised they can put a couple of stents in 2 or 3 hours, and we all hope it goes very well for you. And I don't have any. I don't have any peer advice on heart stents, but if anybody does, now's the time to speak up and give Jim a little encouragement.
Well, I'll put a plug in for them. I don't personally have a stent in, but it's really not a very hard procedure. You'll probably be given midazolam or something like that, and you won't even remember anything. And I mean, I've heard of people feeling more energy the same afternoon. I don't know if that'll happen to you, but uh, I, I'm all for it.
Yeah. Nothing
Maybe
like
you'll be
opening
able
up
to
those
run
arteries.
home, Jim. Maybe you'll
Right.
feel so good. Yeah, you'll be able to jog home.
Right. An hour and a half, they say. Hour and a half. Yeah, hour and a half, and I'm out. Then anyway, out of the room, but I still have to recover from the juice that they happen to give you. But as I say, it will be interesting.
Is this
Yeah,
at Walter Reed?
Negative. This will be at Virginia Hospital Center, Kaiser.
Okay.
don't drive home.
No,
Jim, are you already taking a statin?
yes, I have been. Interesting enough, I tried the statins back in like 2017 and 18, and I could not tolerate the Lipitor or the Crestor. And in about 2021, there was a drug called Pravastatin that apparently the doc said was specifically for folks who could not take the other ones, and it knocked it right down. I mean, it was amazing. Cholesterol, I was probably running on the drugs around 200. Now it's down to 138, and the HDL is above, the norm, and the LDL's below, and no problems at all.
Okay. Very good. We wish you well.
Thank you very
Peter.
much.
Okay. Okay. Steve Rowe.
I'm here. Well, thanks guys for having me on tonight. Good to see everybody. Just wanted to kind of give you a little bit of an update about my trip down south to the Detroit area to see Dr. Elisabeth Heath. She's a GU oncologist. And we had a great visit. She was about 45 minutes late getting into the exam room with me. She is very in high demand. But she was really, really had a fun time meeting with her. She kind of identified me right away as being a bit of a jokester and witty, comical guy. So we had an interesting, fun meeting, and she's decided that that I should probably be back on uh, back on treatments, despite what my local oncologist said. So we're going to go back to taking. She's prescribed Orgovix, and she's going to have that run about 18 months. But she's going to do that second anti-androgen. She's giving me a bit.
Abiraterone.
Abiraterone. Thank you. Why are these fancy words that are in Latin? It's hard to pronounce. But so we're going to run with that as well, and run about 18 months with that. And I have a follow-up. I had blood work done after our exam. She's got a great personality. She seems like she really knows her shit big time. I mean, um, she just seems like she's cutting edge with what's the right way to do things. And I hate to say it, but somebody mentioned to me today, they said, well, it sounds like your old doctor there locally is just doing his job. And Dr. Heath really loves what she does, and she's really going at it full tilt. So I'll get back with you guys with more information. But I had blood work done there that day, and I'll have more blood work on April 22nd, I believe it is. I have a 6 weeks from now. I'll be taking that 4-hour drive back down there to see her again.
Okay.
That's about all I got. She said that, taking the break from the ADT, the Lupron, she said you probably tolerate the Orgovix better than the symptoms I was having with the Lupron. And she said, that there's nothing wrong with just considering, reboot, which my local oncologist never mentioned anything about that. So I'm glad somebody gave me a referral to Dr. Heath. Thank you, Rick, from the bottom of my heart. Really awesome. I really loved her bedside manner, and the friendly, comical banter that we had there going in the exam room was pretty epic. I think her nurse practitioner, the MP or whatever there, she was almost brought to tears when I mentioned. They told me about drug interactions, and they started going through that. And I told them, I said, I haven't had a drug interaction since the 70s, and that's okay. I didn't enjoy it then either. So,
So,
we had a
Steve,
pretty good little laugh. It was a good time, and I'm happy to be
Steve,
back on AT.
we, I thought you'd do well with her. I don't really know her personally, but she comes across so well whenever we've seen her. I know Peter Kafka has seen her and at her presentations, and she seems she seems terrific. And for us, it's really important when we refer somebody. I mean, I often ask if people don't say, "How did you get on with the doc?" Because then we know for the next time. Um, and she is really solid, and she does do a great job. We've got, I think Bill Lee, I think it's Bill Lee, but we've got at least one other person. Bill, are
Yes,
you?
Bill. It is Bill. Yeah.
Yeah, Bill, you see you see Dr. Heath as well, don't you?
Yes, I do.
I mentioned your
Um,
name, Bill. I hope that's okay.
Yeah, that's fine.
so it's great, and we're happy for you, and we wish you the best. Well, I know Dr. Jeff has his hand up. But I have one question for the group, and then we can go to Dr. Jeff, which is what advice does anybody have for Steve, taking into account he's restarting a hormone therapy, an androgen deprivation therapy, albeit Orgovix, and he's going on abiraterone for the first time? Is there anything to watch out for? Is there anything he should be aware of? Anybody want to say anything about that?
Yeah, this is Jeff Gilbert. I hope that they're putting you on prednisone when you're
Yes.
going on the abiraterone.
Yes, that was something she mentioned that was going to have to go hand in hand with it.
Good.
Personally, I had leg swelling and uncontrollable hypertension, so you could keep an eye out for those two things.
And yes, and there are people like Jeff Marchi, for one, who don't respond well to the heart issues. That there can be heart blood pressure issues around the abiraterone, And if these things happen, you just let Dr. Heath know, and she'll switch you to a different type of drug. They don't happen to everybody, but we've known them. We've known them to happen. I mean, Jim, you did great on abiraterone for donkey's years.
For that, but Steve, are you on the 4 pills or the 1 pill?
500 milligrams twice two 500 milligrams once a day, plus 5 milligram prednisone. The Orgovix they're going to load me up with the Orgovix, 120 milligrams per day, once a day, but they're going to do a load at the start. The first day will be 3 of those.
Right.
Okay, now the thing I would suggest, after a month, you should get probably a liver function test.
Yes.
Okay, after a month, after that, it could be 2 months or 3 months. I've been doing a month every since I started. And the catch was, anyway, I was in the thing of the 4 pills of the 250. I tolerated it for a month. Okay, in the second month, the function test showed something. I dropped it to 3 pills of the 250, and after that, I was good.
That's interesting to note. I mean, because it's something that it goes right in hand with what she was saying about I needed to self-monitor my blood pressure on a daily basis, and I have a cuff here at the house. So she said, "Promise me you'll do that. Check your blood pressure daily." And she does want to see me in 6 weeks for more blood work, including some liver function tests. There was also talk about bone density and doing some bone scans. She said that's going to have to be put on the table as well for you
Right.
to go. Yeah, if we follow this regimen, So she was very. I mean, she was very. She included everything. I mean, she went right through exactly a lot of things that I might, that I'm going to have to do, and to be watchful for.
Very good. Is she giving you a standing order for blood tests since it's a 4-hour drive, so you can do them locally?
Locally, yes, she's going to do that after we meet again in 6 weeks.
Very good.
What's going to happen is after I make that next trip down in 6 weeks, that's one of the first things we discussed was getting the blood work pulled right here. There's another place affiliated with their clinic that's just an hour away that I can go get a blood work there. So
Good.
Steve,
Good for you for making the effort to see her. I mean, so many people, will not drive and or not travel to see the experts, but it's your life. It's our life. I mean, it's certainly worth the trip, as you say.
So if you're,
in my opinion, it's just night and day comparing her to the medical oncologist I had previously.
Right.
So it's a huge difference.
Someone was mentioning that in the group last night about the difference between going to UCSF and seeing the experts and seeing their local urologist. And it's I mean, over and over and over again. It used to be years ago that doctors made house calls. Now patients have to make office calls. We gotta hitch our horse up to the wagon and make the effort if we want to go on. Len, you've got something.
Steve, nobody's mentioned this, but when I started abiraterone, I was on, it was Zytiga then, and it was 1,000 milligrams a day like you. After about a month, I couldn't take it. I was emotionally, it just made, I cried at anything. And I dropped, the oncologist said, okay, go ahead, drop it. I dropped it to 750 and never had that problem again.
Really?
Yes. So just be aware of that.
Yeah, you can play with
So
dosage.
you just dropped it from 1,000 to 750?
Right.
How'd
That
you do
was,
that? I mean, I've got 500 milligram pills. Am I gonna have to break them in half or what?
No.
Yeah, you
no,
might
you
have to.
just get a 250.
No.
Okay.
No. Uh, the stuff comes in 250 pills.
Oh,
The other
okay.
Yeah.
thing, the other thing is, Steve, because I know you've done this before, we would say don't self-medicate. If you've got an issue, let Dr. Heath know and she'll respond to you, and do whatever you do with her blessing. Just don't, because you wake up one morning feeling teary or what have you, don't think, oh, I've got to take 750 instead of 200. I mean, we can give you the information, but it's not for you to self-medicate. Really
I will
important.
I will check with Dr. Heath first.
Okay.
Okay. Just saying,
Len, Len,
yeah, you've got a bunch of people, I think, in the chat window,
yes,
in the
yeah.
hands up.
Len, go ahead.
All right, Peter, thank you. I have a question for Dr. John, actually. When you were on Abby and you had hypertension and leg swelling, what was your dose of prednisone?
It was 5.
Okay, so you may recall coming out of the GU ASCO 2024, they said that the incidence of hypertension and edema and hypokalemia, low potassium, was much lower if you took 5 milligrams twice a day.
Right.
So that's something to talk to Dr. Heath about, Steve.
That's going to
See,
be, instead of taking two 500s, you're
No,
saying take
no,
one.
no, I'm talking about the prednisone. When you take
Oh,
Abby,
yeah,
you have to take prednisone. And
right.
some docs give 5 milligrams, some give once a day, and some give 5 milligrams twice a day. And there was a recent study that showed that side effects were lower with 2 5 milligram doses of
Okay,
prednisone. Yeah.
okay.
well, see how you do. Don't get ahead of yourself on this. See how you
No,
do on this.
no, I'm not going to do that. I'm going to be in close contact with Dr. Heath. She's got all my respect and trust. Uh,
Jimmy Greenfield, go ahead.
Question. How much do you exercise and what kind?
Yeah.
Me?
Yes, you.
Well, since I stopped the Lupron injections, I got so much of my energy back that I actually joined the local health club, and I try to get down there as often as I can. If I'm lucky, a couple times a week, but I'm always out trying to walk. I live up here in the northern part of Michigan, so we're having a heat wave here. We're 35 degrees above normal, having some 60, 70-degree days. So I'm outside and I'm trying to walk, hit the trails, walk my new dog. So I consider myself
I
pretty
don't have to
active.
tell you. I don't have to tell you, Steve, that if you got off of Lupron and you were feeling so much better that you exercised, you're getting back on ADT now. So
I
if you
know.
get back on ADT and you don't exercise, you're in trouble. That's all I got to say
Well,
about that.
well, the prednisone might help with that.
Uh, don't look to the prednisone because the testosterone deprivation wastes your muscles. And if you get behind too far, it's very hard to come back. And that's what drives the fatigue. Exercise is the key to minimizing the side effects of all of this. I would say the prednisone, I mean the abiraterone as well, but there's no data on that, I don't think. But certainly the whether it's Lupron, Orgovyx, or anything else, exercise is the key to minimizing side effects.
Okay. Jeff Marchi, any comments?
Yeah, just to let you know, I tried going down to 750 from 4 pills because of the brain fog, and within 18 days, my PSA rose from zero point 0.2 to 1. So it may not be the best thing for you to do to stop. If you do, make sure you get a PSA test. I guess you're probably going to get them once a month anyway. But going to 750 doesn't work for everybody. And another thing is, going to Abbey really increased my hot flashes. I mean, a lot. So if you have a problem with hot flashes, come back and there's a lot of recommendations here.
Okay.
Jim Marshall, one last comment.
One last comment exercise, I believe, should be aerobic exercise. Walking, you know, the dog, well, I don't know, but aerobic exercise. I did that practically every day, basically on a bicycle, not hard, but I was out, humping on the bike, and it really helped. And the catch is, provided you are tired, you've got to exercise. You have to force yourself out to do it, because if you don't, you'll get tired and more tired and more tired. It was a drag at first to attempt to convince the body that it had to exercise. But if I did that, I got better. Okay, and the brain fog too was then gone also. Okay, the blood was flowing and all of that stuff. So good luck.
Well, thank you. And I forgot to mention, we do have, my wife and I bought a pair of new bicycles last year. So we're starting to bike like crazy now. So.
Good. Way to go.
Yeah.
Yeah. And train that new dog to throw sticks that you could run after.
That's what he does when I throw the ball. He doesn't bring it right away. I have to chase him down.
Good. Okay. Let's move on to Chuck Snyder. Chuck, go ahead. You're muted.
Okay. How are you? How's everybody doing? So just to give everybody an update on my I had my third Pluvicto treatment 3 weeks ago, and it seems to be working well. Since I started, my PSA has gone continually going down, but I noticed, I think I mentioned last time that after the second treatment, I had bad nausea. Now the first treatment it was 2 days of nausea. The second treatment was about a week of nausea, and the third was 2 weeks of nausea. So I contacted my oncologist, and they gave me Zofran, which really really helps with the nausea, but it just hangs on it seems to get worse as the treatments go on. And another thing I noticed was, I'm very active. I exercise. Twice a week I do weight training, and I try to ride my bike twice a week also. But I noticed since taking the Pluvicto, I just have horrible joint pain and muscle. I seem to pull muscles very easily, like especially my hip, my right hip. I was working out with, I don't do heavy weights. Maybe last Sunday I did some, light dumbbells and some, rubber bands and things like that. But I just got up and I, pulled a muscle in my hip. It seems to be related. I don't know. I'm wondering if it's related to the Pluvicto. I contacted my oncologist and told him about the symptoms, and he's thinking maybe reducing the dose, by 20%. That was his thinking. But then I'm wondering, maybe could it just be so many years of being on ADT? It's just pretty much destroys your muscle tissue. Even though I'm trying to lift weights and ride my bike, and but over time you lose muscle mass, and so I'm just wondering if it just the years of being on the ADT is causing me to pull muscles all the time. It seemed to be pulling my muscles. It's horrible.
So I'm gonna give you an email address. I'm gonna put it in the chat window.
Okay.
There was a poster. I don't know. Did you watch our GU ASCO presentation, Chuck?
GU. That sounds familiar.
We did a webinar was it 2 weeks ago? We did a webinar 2 weeks ago before the meeting on what we thought were the better posters from and better presentations from the GU ASCO meeting in January. And that was, I featured it again in the reminder this week. It's on the front page of our homepage. You can find it on our homepage. And this is now, I'm going to cite another paper. Len already cited one that we brought to your attention. Here's another one that came out of that. And this was a study done at the University of Kansas. They had a poster. I forget right now how many people were involved. It wasn't a lot. And I don't even want to say, I'd need to go back and look at the poster, but they looked at muscle pain, pain after you started Pluvicto. And almost all, I think all of their people, their pain resolved within, I think it was 12 weeks of starting. So by the time they got to their second session, they weren't dealing with any issues. Now, the researcher, the PI was a guy called Dr. Lee, L.I. And of course, everybody who is in that has been through a lot of ADT. Otherwise, they wouldn't be at a stage of Pluvicto. So I'm going to give you his email address, and you can tell him that it came from AnCan and from me. Hopefully he'll remember meeting me. I gave him a card, but he may not. And ask him what he found out in his study about how long these pains, because then you're basically getting it from the horse's mouth.
Yeah. Okay. Thank you. Appreciate that.
Okay, so I'll send it to you. I'll send it to you right now. And let me also do this for good order's sake. Let me pull up the poster, just unless one of the guys remembers the poster better than I do, which so hold on a minute. Slides. Hold on a minute. Here they come. So I'm just looking at the slides because we made all those slides available to you. And again, he's not here, but he'll be listening tonight and tomorrow. Just a huge thank you to Ben Nathanson. Every time I look at these damn slides, I'm so grateful. He did such a terrific job in putting the slides together. If you haven't looked at this, it's definitely, the slides are definitely worth looking at. So this is titled Pluvicto Flare Largely Lasts Only One Treatment. PSA flare in patients with metastatic castrate-resistant prostate cancer undergoing Pluvicto. So a University of Kansas study examined 53 patients, of which 7 experienced PSA flare and 2 experienced PSA flare and bone pain within about 2 weeks, followed by 12 weeks of PSA decline. So everybody who had the flare, it declined quickly. Now, we know that's not true for everybody because Jerry Deans, God rest his soul, had bone pain through like the 4th session. So, everybody's different, but by and large, people don't experience bone pain much beyond the first treatment.
Okay.
Okay.
All right.
Jim Barnes, what's your experience with Pluvicto?
After I've had 8 Pluvicto treatments and an actinium treatment, and throughout I've had varying types of bone pain, and it feels like the areas that are where my cancer is in my body. So in the back of my mind, I'm hoping that that's my cancer reacting to the radioligand technologies, the radioactive stuff they're injecting in us. But I just wanted to say I share your experience with the bone pain, but I have not pulled any muscles or anything like that. But all I'm doing is walking, a little pickleball, and some other activities, nothing serious.
Yeah. Where was your did you have pain in your knees? Like I have pain in my knees and my shoulders and my my joints. When you say bone pain, do you mean like in your
It was
femur or?
in my hips and my back, and that's
Oh,
primarily where the big lesions are. So
okay.
that seemed to have pain.
Okay. Thank you.
So sure, anytime.
Okay, guys. Thanks for the advice. Appreciate it.
Yeah, good luck. So you still got 3 more treatments to go?
Yes, I do. Yes.
And what is your PSA doing?
My PSA was always very low. When I got the highest it ever got was 35. So, but after my chemo stopped, after the chemo stopped working, it started to go up. But then when I started the Pluvicto, it was about 1.2, and then it went down to 0.4, and then down to 0.3. So hopefully it continues to go down.
So I heard another very interesting presentation. I heard another interesting presentation this week from by Joshua Lang. I sent it to the Brains Trust, and he's been doing some studies on liquid biopsies, trying to identify markers, and this gets pretty complicated. It's sort of along the lines of what Dr. Bob talked to us about last week with proteomics and RNA and other things. But what they're trying to do is to figure out when men are becoming, when they're morphing, when small cell activity starts to take place. And he thinks that there are markers that do this. Joshua Lang, by the way, is a very good GU medical oncologist. He's treated 2 or 3 of our guys, and he's based out of Carbone in Madison, Wisconsin, Carbone Comprehensive Cancer Center. And the reason I bring it up is because whilst he doesn't really talk about treatments, he's really using these as diagnostic tests and maybe an indicator when to start treatments that might be more appropriate to small cell disease. And I haven't heard back from the other guys, so I don't know if they watched it, but I will put the link in the chat window for everybody. I will say this: it does get very technical about halfway through, and I think I gave up at about 40 minutes. So it was above my pay grade, but the first 20 to 25 minutes I did do pretty well. So, but we need people like Len and Ben to watch it and to synthesize what they see. But I'll put it in the chat window anyway.
Okay. Okay. Okay, we're going to move on to Alan. You need to leave early, so go ahead.
Yeah, and this will be real quick. I started having some blood clots in my urine, and I wanted to ignore it, but my wife disagreed. So you all know how that goes. Once she decides I'm going to act on something, it's best to do it. So I went to the urologist, and he checked it out, and he did a cystoscopy. I can never say it right.
Cystoscopy.
Thank you. And he, it was. He looked inside my bladder and showed me how. He said, this is a gift from your radiation. I said, my radiation was 2 years ago. He said, Alan, that's the way it works, And I did not want him to do the procedure because it sounded too painful to me, and it was not at all. And Rick said, yeah, it wasn't either. So if you've had radiation and you have any blood in your urine, I mean, good to have it checked out, but that's what I found out it was from. So I just wanted to put that out there for everybody because I haven't heard us discuss it.
Yeah, radiation keep on giving, and it can do a number on your bladder, and it probably has some effect on your urinary frequency and so forth too. And the elasticity of it and so forth. I know it's affected mine, although I've never had blood clots. But
And it was interesting because he let me see inside of my bladder, and he said, "There it is. See that little red spot? That's where they're coming from." Okay, fine.
yeah, it's not ready for prime time TV, but it's pretty darn close.
Yeah, it's interesting.
It's funny that, Alan, it's funny you say you don't hear us discussing it. It sort of goes in cycles. We have discussed it many, many times. When we have patients who have significant issues with radiation cystitis, it does usually come up. I think Ravi was probably the last guy when we talked about it, and I think you've been with us. I think you've been with us since Ravi, but we don't see Ravi always. I think he listens now on the. But yeah, it's a subject that we have experience with. Many of us have experience with, and we really want the takeaway message to be to all of you: don't freak out when you see it. Don't freak out. It happens to a lot of us, and it's relatively normal. Same thing with radiation proctitis, and if you see blood in your stool, that's very often what it is. I remember that. I think the first time I had a sigmoidoscopy because the doc didn't want me to have a colonoscopy, and they pointed out to me that time where the inflamed part of the bowel was, and you see it. It's all like red.
Yeah. It's amazing. It's amazing when the thought of threading a TV camera up your penis is kind of weird, but it's really pretty non-invasive. It's not a big thing once you do it. Okay, thanks, Alan. Herb Courtney.
Yeah, thanks, Peter. Well, last month I had my routine quarterly blood test and then subsequently my meeting with Dr. Rettig at UCLA. And I'm just on darolutamide now. And my PSA was the same as the previous at 0.03. So as Rick said, it's just low. It's just really low, which is great. And concurrently, my testosterone went up a little bit. I don't know that it's significant, 193 up to 216. So all's good. We're going to stay the course. He did offer that if I really wanted to, he'd be comfortable with me taking a bit of a drug holiday. But I said, well, I'm tolerating the darolutamide so well, and I'm very fortunate it doesn't cost me anything. So we're just going to stay on it for now. I had my last 90-day Lupron shot about a year ago, and finally the hot flashes are starting to get significantly less frequent and less severe. So that looks like it's winding down. So that's all good news. One thing I wanted to mention was back when I was on Lupron, we talked about exercise and Lupron and fatigue. Back when I was on Lupron and enzalutamide, I had a lot of fatigue, which turns out it was the enzalutamide, not the Lupron. And after I was off enzalutamide and on Lupron, I was still able, again, we're all different, but I was still able to work out. I work out vigorously 3 times a week, usually about 2.5 hours, both weights and cardio, and never had a problem with just the Lupron. The only problem with it was those bloody hot flashes. So that's the situation for now.
Good for you.
Herb,
Yeah.
it's John. I may be in a situation like yours in the next couple months. How did the discussion go uh, when you got on darolutamide? Was it because of the hot flashes that your doc said, okay, let's drop one and keep the other, or how did
Yep.
you end up getting on the monotherapy?
Well, the fact that with the Lupron and the enzalutamide and then also switching to darolutamide, my PSA had just nosedived. And so the fact that the Lupron was pretty uncomfortable, Reddick said, I think you're going to be fine just on the darolutamide. And he's been right so far. I'm kind of hoping it's not bottomed out at 0.03 and starting up. But again, as Rick said, 0.03, 0.02, 0.04, it's just low. So that was the discussion, that he just felt that I would do just fine, which so far is correct.
And it probably keeps your testosterone moving along like it is. Len, you've got some.
When I was on the Lupron and the other glutamides, my testosterone was basically undetectable. It was so low.
Right.
But
Len,
again, it didn't bother me exercising though, which is kind of weird.
Len, you've got a comment on that, yeah?
Thanks, Peter. I wanted to ask Herb, did you switch from enzalutamide to darolutamide because Enza wasn't working anymore, or you just were uncomfortable with the side effects?
I was uncomfortable with the side effects.
Okay, so it was still working.
It was still working.
Okay.
I actually, well, I don't want to get into too long a story, but I actually got off enzalutamide and was just on Lupron for a short period of time. This is before I went with Dr. Reddick. And then when I got to Reddick on the Lupron, he kept me on the Lupron and added the darolutamide and then got me off the Lupron.
Okay. Keep it up.
Peter.
Sound like you're doing well. Go ahead, Rick.
Peter, just 1 second. I'm just going to put a plug in for a new group that we have in formation right now. I just sent a note to Herb Courtney. But we are very soon starting a new care partners group for people looking after folks with either motor or neuro conditions. And so if you know anybody, just keep us in mind when we launch it. We'll be putting it in all the reminders, but it could be a real life-changing group. It's going to include people who are looking after folks with Parkinson's, multiple sclerosis, muscular dystrophy. Alexa's going to lead it because her fiance is hemiplegic from some brain mets. He's doing great. He's now playing pickleball again, and goodness knows what, but he is hemiplegic. So if you know anybody, you've got any friends who fall into that category, those care partners desperately need help, and we have a few of them in our group. So
I'm a care partner for my wife who has Parkinson's.
Correct. And I just sent you a little note, so we'll be in touch with you.
Thanks.
So, because what we do is when we run a training session for the new moderators, we like to invite people to participate in that group who are friends of the house, who are peers, but they're friends of the house. So that if we have to jump in and help training the moderator, we've got friends of the house who are there before we go public. So
Yeah. Probably includes the unfortunate people who take care of people with ALS too. And they got
yes,
a rough
oh
go, I think.
yes, oh
Yeah.
yes, yep.
Okay, Steve Schuler.
Yeah. So my status update is I had my DEXA scan 11 days ago, and I've gone from defined as osteopenia a year ago to now osteoporosis. And so Dr. Sankara said, well, let's put you on Prolia, denosumab, and so then we'll just wait for the insurance approval. And and a few days later, got a call or a text rather saying the insurance had denied it, and they want to put you on Zometa instead, zoledronic acid. So that's United Healthcare. Researched it. I've looked at past things from this group on the subject, and then talked to the pharmacist there, and the nurse. My doc was not available, so I have some more questions for her. But I decided after all to just go ahead with the Zometa. So I started on that yesterday. And so my question really for this group, so it was hard to get this. I actually got it through my doc. What was the reason for United Healthcare's denial of the Prolia? And what they said was our insurance policy specifies that you must fail Zometa first before we will pay for Prolia. It wasn't those exact words, but it was essentially that. So I asked the team, what does failure consist of? And the answer was, well, you don't tolerate it, or it fails to actually increase your bone density, which is not something you would know for a long time, really. But now my question really, or questions. So I guess, and this is for the entire group really, is this something that is common? I mean, is that the kind of behavior of insurance companies we see? I suspect it is. And then do people actually end up failing Zometa? It seems like, it's going to, if there is, well, aside from side effects, I know some people get bad side effects. So far, I don't seem to have any. It's only been like a little over a day. So, but do some people fail to increase their density? And how long do you know that is the case? How long does it take before you know that is the case? So those are kind of my questions.
Len, you've got experience with some of this stuff, don't you?
Yes, I was taking Xgeva, which actually would have been the right script for you, Steve, rather than Prolia. They're the same drug, but Xgeva is twice the dose and twice the frequency. Do you have bone metastases?
No, I do not.
Oh, you don't. Okay.
So I think that's probably why.
Yeah, that could be.
I'm not there yet. For me, it's only gone as far as my lymph nodes.
Okay, so I would guess the only way to get away from the Zometa is, as you said, if you report side effects. But I'll say this, I don't believe that Zometa is any less efficacious than either Xgeva or Prolia. I'm not aware if it is. It's just I think a little less convenient because you've got to sit in a chair with an IV running for, I don't know, 40 minutes or so.
It was like 20 minutes or something.
20.
It wasn't that bad, yeah.
Yeah, Xgeva, they just give you a shot, sub-Q, I think it is, and you're on your way.
Don Rogers.
Yeah, hi, Steve. Did you take an appeal of the denial from the insurance company?
I did not. I considered whether I wanted to do that, and it was, I think, mainly because of my reading of the medical efficacy seemed to be that it was as efficacious. So based on that, I decided, well, okay, I wouldn't appeal it.
Okay, because I know I've worked with other people before, not myself, but friends and relatives. And normally, if you have your doctor write a letter saying that this is medically necessary, and you write another letter saying, I want my doctor to practice medicine, not the insurance company, they normally will provide you with the drug that the doctor wants. I would highly suggest that you take an appeal.
Right. At this point, it seems like I'm committed because I already got my shot, right? So I don't even know if it's advisable to overlap those two drugs. Apparently, the Zometa incorporates into your bone and has a half-life measured in years. So at any rate.
Okay.
Do you know how long? This is really a question for my doc, but do you know how long the cycle is for the density measurement? I mean, I'm assuming that it's going to take a while before any density improvements are going to be visible.
Usually 2 years.
Yeah.
Yeah. And keep exercising.
I think, I mean, I have a few things to say on this. Is there anyone? Why don't you go through everybody with their hand up first?
Dr. Jeff wanted to say something.
Go ahead.
Are you there? Yeah, did they look for a reason why you have osteoporosis instead of just treating osteoporosis?
Yeah, it seems to correspond with having gone on the LuPARP a year ago.
I would advise. I mean, I was on Firmagon. I'm on Eligard now, abiraterone, prednisone, and I would advise. And this is very simple. I brought it up before, but get a 24-hour urine calcium quickly, and see how much calcium you're spilling in your urine. About 7% of people lack the ability to resorb calcium in their kidneys, and you spill it out. And that's why you get osteoporosis, because you don't have enough calcium in your body to build your bones, right? The body maintains serum calcium at all costs. So when you're not having enough, it pulls it out of your bones and you get osteoporosis. But if you're spilling it in your urine, it's treatable. You take calcium, you take vitamin D, you take hydrochlorothiazide, you reduce your excretion, and you're not pulling anything out of your bones anymore. And it's a simple test.
Okay,
Sounds like really.
So I am on calcium and vitamin D, but hydrochlorothiazide.
Well, that's only if you spill. First, you got to get your urine tested.
Yeah, they've done blood tests, but not urine
No,
tests.
got to be a 24-hour urine for calcium.
Huh. Okay.
Really good advice, because most of us, almost probably all of us, have been on androgen deprivation, sometimes for years and years, and very few of us have jumped from osteopenia to osteoporosis, particularly in a year. I mean,
Right.
it's pretty unusual, unless you've got some pretty heavy bone mets or some kind of thing going on in your family or something. It's not usual. So I'd take that advice and push on your doctor to look into this more.
Huh. Okay. Yeah. I mean, I've looked at the DEXA scan between a year ago and the one I just got, and yeah, I mean, it's very noticeable the change, and that going from osteopenia to osteoporosis. So it was a pretty rapid change, which is not normal, you're saying, or maybe a little outside of the normal range.
Usually that fast. Rick, you've got something to say on this.
Can I
Or
ask a
Jerry
question?
Grimes. Go ahead, Jerry Grimes, and then I'll talk.
Oh, okay, thanks. Yeah, my first bout on Lupron, I verged on osteoporosis after about 18 months. I went from normal. I had a baseline DEXA scan, and after about 18 months, I had another, and I was at my T score was minus 2.3. Steve, do you remember your T score?
Uh, yeah, in fact, I thought maybe there would be a question, so I have the doc
Minus
here.
2.5 or less is typically osteoporosis. So I was on
I
the
have,
brink of it.
so lumbar spine, it's L1, it's negative 2.1. Left hip, it's negative 1.7. And left femoral neck, it's negative 2.9.
Okay, so it's just barely into the osteoporosis region. I did go on Prolia, but in case you're kind of anguishing about Prolia, that's not a slam dunk either. The risk of jaw necrosis and a few other things with Prolia are to be taken seriously. I had to get a clearance letter from my dentist before I could even go on it because of that risk. If it happens, it's a pretty unpleasant side effect. So, and even getting off of Prolia one day is a little tricky. It leaves you at risk for a certain type of femur fracture later on. So it's not a slam dunk either. All of these things are a little bit of a balancing act, but I do recommend the DEXA scan, a baseline for everybody going on ADT, and get it checked every 2 years because we don't know how fast it can deteriorate. And for some of us, it might have been more. And I never had that urine calcium test. That's an interesting one. I hadn't heard of that.
Yeah. And I was able to get DEXA scan after a year, and I'm glad I did, but I
Yeah,
had to push
absolutely.
for it.
Yep. Good for you.
Rick, go ahead.
So, when I was diagnosed, fortunately, I had a really great urologist, and he ordered a DEXA scan for me right up front. And I was amazed to find I was borderline osteoporotic. I think I was minus 2.49 in my back, and so he ordered for me. This was back in 2008-7. Zometa, zoledronic acid, and I had 3 treatments of zoledronic acid over 2 years. To begin with, after 12 months, and then after 24 months. And I also changed my exercise schedule to try and do more resistance exercise, or put more weight resistance on my back. And sure enough, when I started, I was minus 2.49, and when I finished up, I was minus 0.9, and I'm now back to about minus 1.6. And I'm probably one of those people that Dr. Jeff refers to, who does have a family issue, and I do get rid of too much calcium, but I can't use, I don't do well on hydrochlorothiazide. That said, I do think that denosumab is a superior drug. There is evidence out there, and we seem to think it's a little bit better. I put one article in the chat window just now, and if you look, by and large, it is probably a little bit better drug. It is a newer drug. It does work as a monoclonal antibody, is the way that it functions, and it works a little different. That said, the Zometa works. And if you don't, and I never had any side effects to it. I mean, I know Len, two of our guys, Len and one of our other guys had real bad flu-y symptoms from it. It never bothered me, and it seemed to work. It's really disappointing for me to hear that United Healthcare is not accepting Prolia or denosumab in this day and age. I mean, it's ridiculous. But if you want to make if you're happy with the zoledronic acids, stick with it. The two things, the teeth issues with both of them, it's really important to get everything done first. The other side of that coin is if you don't do it, if you have issues and you have bone density issues and you don't take, you can have serious repercussions. Alexa just had a rear tooth disintegrate on her, probably as a result of hormone therapy. And she's not taking a bone strengthener, and she's going to start taking a bone strengthener. This is from her thyroid cancer diagnosis. So yes, it's that's my 2 cents. But hopefully you'll be the same as me, Steve, and you'll take it for a couple of years, and it'll build you back up again. So.
Okay. So, Dennis, I'm going to move on. I want to move on to Jim Barnes and make sure he has time before the end of the meeting. Okay. And Dennis, we can come back to you afterwards if there's time. Okay, Jim, go ahead. You're the last one on my list anyway.
Thank you, Peter. I just wanted to mention I had my as I went overseas to get treated with more actinium and lutetium, and I came back right before my last lutetium treatment. My PSA had skyrocketed to 54, which it had been rising. That's why I went overseas to get treated. And but last week I had a PSA of 15, so I had a drop from 54 to 15 last week, which is like 70% drop. So hopefully that's the start of good things to come. And so I would mention to people that I think that the lutetium and actinium, they take a while to work after you've had the treatment. It's not an immediate effect. The theory is that you screw up the chromosomes in the cancer and it can't reproduce or dies when it tries to reproduce. But I just wanted to pass that along, that I thought my PSA dropped, so hopefully things are looking up, looking down.
That's great. Good news. How often you check? Every month, I'm sure, yeah?
That's what I'm aspiring to do, but so I get to get the more scripts written for more PSA tests. As I'm down here in Florida, I'm getting the blood test done at Quest.
Okay. Any questions for Jim?
How do you feel?
Oh, I feel fantastic. Oh, by the way, after the last lutetium treatment, my PSA had been rising. It was up to 54. The doctor prescribed olaparib, a PARP inhibitor, in addition to the lutetium. So I took both. I had the lutetium treatment followed by a couple of weeks of PARP inhibitor, which is supported by, there's a study out there called LuPARP, LuPARP. And I think that was done in Australia. I'd be interested to hear any of the Brain Trust comments on that study. But from what I saw, it was very positive. and that's why the combination of lutetium and the PARP inhibitor. But after I stopped taking a PARP inhibitor, I felt great. The PARP inhibitor, it is toxic. It raised my ALP and some other blood markers that indicated that my liver was being affected by the PARP inhibitor. So I've stopped that, and boy, I felt better than I ever have. I mean, except for the muscle that I've lost over the years of ADT and all that. Which I did have a question. Does anybody? I mean, this group is very pro darolutamide, and my doctor wants me to continue with Eligard shots. Is there an argument for asking my doc to put me on darolutamide instead of Eligard, darolutamide alone instead of Eligard? I just wonder if anybody might have any thoughts on that.
Well, you'll definitely feel better.
Well, I tell you what, by the way, I had Eligard shot in November, which should have long worn off by now, and my testosterone was 14, so still ridiculously low. Even though it's been 3 months or 4 months since I've had a Eligard shot. But the Eligard never made me feel bad, but I just was wondering if the darolutamide might be more efficacious in terms of keeping my PSA on a downward trend.
Do you have a second doctor that you use in Florida? Do you have one in Florida and one in Pennsylvania? How do you
No, I don't. I had a telemedicine. I had a telemedicine appointment with my GU onc in Pittsburgh from down here, and I've been communicating with my doc overseas as well.
Well, I don't know, Len. I mean, what do you think on that? Go ahead, and then I'll put 2 cents in.
Yeah, first of all, congratulations, Jim. That's great news. I'm very glad to hear, especially that. So you had lutetium and then followed by a PARP inhibitor, right?
That is correct.
Yeah, and it worked. Seems to have worked for you.
That's apparently the case.
Okay, because at the GU ASCO conference a couple of months ago, if that order, if that sequence was reversed, if you had a PARP inhibitor first and then lutetium, this one study that they published or presented at the conference indicated that the lutetium response was much worse in any patients with a BRCA mutation who had the PARP inhibitor first. So you had the opposite. So it could be a sequencing thing and not just a cross resistance thing. Yeah.
And I am not BRCA1, BRCA2.
Oh, okay. So
this is again the LuPARP study, LuPARP, that indicated that people had a deeper PSA response with the combination of lutetium and a PARP inhibitor. But as Rick pointed out, the PARP inhibitor is very toxic and definitely was messing with my blood levels.
Yeah.
And how long in LuPARP did they take the PARP inhibitor for?
And I'm not sure about that, but my nuclear med doc who provided the actinium and the subsequent lutetium indicated that several weeks for enough was due for the dual combination effect of the lutetium and the PARP inhibitor.
And how long did you take it for, Jim?
Probably 3 weeks.
So again, I wonder whether I'd be suspicious of whether whether the PARP inhibitor had enough time to even play a role. I don't know. I just don't know. The problem with those PARP inhibitors they are really toxic, as you found out. And so if you don't tolerate them, they can be serious. And that's why we tend to tell folks, if you don't have the right mutations, don't mess with the PARP inhibitors. That's something that we've been saying to Peter as well recently, Peter Kafka. and they're nasty. They're really nasty. So we'll need to look at LuPARP. My guess is that the reason you're responding so well is to the actinium. One of the things that's sort of interesting is that in your case, I think it was married to a small cell ligand, which is not, we don't think it's as good as when you marry it to a large cell ligand. And the large cell ligand, that's the trial that we hope to be featuring in April or May that's supposed to be starting here in the next few months. So, we're real interested to see how that does. But clearly the actinium is a powerful drug.
Well, I have my next PSA scheduled for April 4th, and I think that'll tell the real story.
Yeah, you look great. I mean, you got a $1 million tan there. So
Yeah.
something's going right in Florida.
Yeah, and I feel great to answer Jack's question. I really do. So I'm taking every minute of that feeling good and enjoying it.
God bless you.
Great. Okay.
Dennis, I agree. I tend to agree with you, Rick, that Jim's response is probably from the actinium and not the PARP inhibitor. I just took a quick look at LuPARP. It was only a phase 1 study, so it really wasn't even designed to show efficacy. Although they did see some PSA response. But yeah, I wouldn't put too much faith in that combo right now. We'll have to wait and see what the later trials show.
Yeah.
But
I've
probably the actinium.
I've exhausted all my standard of care options, so I'm in uncharted water. I'm kind of with Peter Kafka now. It's kind of work with the best doctors, the best evidence you have that something's going to work, for sure.
Right. Yeah. The only flag that comes up to me that I've been thinking about is, when you travel and you park yourself someplace, you got to make if your doctor doesn't have the license to practice in the state where you're staying, you want to have somebody that can back you up and write a prescription, particularly when you're dealing with drugs like Rick says that can that require pretty close monitoring, like a PARP inhibitor or a immunotherapy or anything that can really mess with you. You want to be able to act quickly, and if your doc can't write a prescription or isn't licensed to practice in the state where you're staying for several months, you want to make sure your ass is covered in those situations. So even if it's not an expert, just somebody like I have here who can listen to other doctors and move fast if they need to. So it's helpful.
I can see where that could be helpful. Absolutely.
Yeah.
Thanks.
So it's interesting that this LuPARP study, which I'll put a reference to it in the chat window right now. It was defined as being successful through the measurement of circulating tumor cells. That was one of the measurements. Also PSMA and PSA response. So and it did include 6 sessions with increasing amounts of olaparib through the trial, of PARP inhibitor through the trial. So these people were on PARP inhibitors right the way through, getting a dose every 6 weeks. So
a dose of lutetium every 6 weeks?
Yeah.
PARP inhibitor.
No, PARP inhibitors
inhibitors every day.
increasing right the way through daily, I suppose, but increasing right the way through, and lutetium every 6 weeks. But they were on the PARP inhibitor for, I guess, for 36 weeks. That's what the trial results appear to be based on. So, and 2 patients with BRCA2 loss and 3 patients with ATM loss had a PSA 50 response by week 12. So, and there's more. I'm reading it very quickly, but there you go, guys. You can read it yourself right there. You can read the LuPARP study in the chat. It's in the chat window. But whatever it is, we're very happy that you got a response. Delighted.
Yes.
Yeah, so far good.
Very good.
We'll let you know in a month how the PSMA goes.
Okay.
Okay. Dennis, I'll come back to you now. What did you have to say?
It's too late. This was relative to Steve's issue with Prolia being covered. I just wonder if he has United Healthcare as his primary insurer, or is it after Medicare? Because I have United Healthcare supplement plan to my Medicare, and they cover my Prolia.
Well, unfortunately, Steve had to drop out, I think, a few minutes ago.
Yeah.
But
Yeah.
so I won't know that. But yeah.
I
Sorry.
think
Okay.
let me just have a look. Let me have a quick look and see how old he is, and we may be able to answer your question from that, Dennis. Let me just see. Steve Schuler. Steve Schuler. Here we go. No, I think his was, I'm pretty sure it's a supplement plan like yours. So here's what I'm going to do. I'm sending you his email, Mr.
Okay.
Correa.
All right.
It's
Thank
coming.
you.
It's coming through right now, and you can tell him. Who knows? I mean, it's strange to me that they turned down denosumab. It is real strange to me, but who knows? But
Okay,
thanks for speaking up, and thank you for reaching out to him, Dennis.
Okay.
Okay, I'm at the end of my list. Anybody who came in late or anybody else have some parting thoughts or questions? Les, how are you doing? You doing okay? Okay.
Hanging in there.
Hanging in there, yes. We all are. Anybody else? Some people came in late, probably with the time change or whatever. Some have left.
I have a question I'd like to ask Jeff. What is the upper limit of normal 24-hour urine calcium? So I just have a reference point academically, if you have a moment. Hey, Jeff?
Yeah, it should be around 220 or less.
Okay, got it. Thank you.
Hey, Rick, I have a vague recollection several years ago seeing a trial showing that in patients who did not have bone metastases, that initiating denosumab wasn't beneficial. So it's beneficial after bone mets, but not before. But
I don't remember that, but
I'll have to try and find that.
It
I'm just
wasn't
wondering if that's why they
beneficial
didn't
for
approve it.
osteoporosis.
Sorry?
You're saying it wasn't beneficial for osteoporosis treatment?
I honestly don't remember the study well enough. I thought it was in showing it wasn't beneficial for cancer patients, not simply for patients with osteoporosis or osteopenia. Anyway, it's best I don't really comment on it. Let me research that. I was just thinking that might
Okay.
have been why the insurance company denied him.
Yeah, could be. I mean, look, in my case, it wasn't even an option because the Exgiva hadn't even been approved at that point in time. I think it was approved around 2010 or 2011 from memory. So it hadn't even been approved. So it wasn't an option. It wasn't an option for me. And I don't think there's a huge amount between them. But they work in very different ways. That I do know. The way that they build bone is very different.
Okay, anybody else have any parting thoughts, questions, concerns before we?
It's 19 hours.
Oh. All right.
Okay. Well, it's been a great meeting. Thank you very much, everybody.
Thanks,
Finish
Peter.
to
Thank
the
you,
wire.
Peter.
Good job,
Okay.
Thanks,
Peter.
Peter. Good job. Good night,
Thanks, Mike.
everybody.
For next
Thank you,
week.
everyone.
Okay. Take care.
Great meeting.
Len, don't forget to send me a reminder,
You got it, brother.
intro.
I
Okay,
know.
goodbye.
Bye.